Hello and welcome to Slice of Piefer. I'm Dr. Piefer.
I'm Taylor.
What's your nickname today?
I don't know.
Not emotional support PA.
No, we've done that one too many times.
Thanksgiving turkey.
PABF has been done now too.
Yeah.
Yeah.
And we have the wonderful and amazing privilege of having Otis Naik with us. Dr. Naik is a nephrologist here in the Woodlands. You've been here for the last 10 years, right?
Yep.
And you've been with Memorial Hermann for the last 10 years.
Yeah, I rotated at Memorial Hermann primarily for about 7-8 years. Yeah.
Awesome.
Right before the pandemic.
And we last saw each other at Top Golf at a Memorial Hermann event. How'd you guys do?
I did okay, better than I thought I was going to do.
Nice.
The clubs were shorter because I'm a tall guy, and I thought it was kind of tacky to bring my own clubs. But
Yeah. A few people did bring their own clubs.
They did. And I was like, oh, well, could have. Yeah.
But
All good.
Those were not tacky people though. Not tacky.
Not techie people, but all good. Well, welcome. Thanks so much for coming.
Yeah.
We're just going to take it easy, hang out, and chat a little bit. We talked about, some of the orthopedic surgeon's greatest fears as we get into the internal medicine world, nephrology, kind of things that we just don't understand anymore.
Right.
Is we had to learn all of this, and then now it seems to have just seeped away into just a world of bones.
Yeah, and it's usually we don't get to interact much. When we do, it's like, okay, I already know what's happening. A lot of Toradol given, and and a lot of Vanc or something like that.
Yep. And the kidneys are literally screaming.
Yeah,
saying, "Please stop."
Yeah, please stop. And now we walk in, we're like, it's going to be fine. We got this. We got this. Yeah.
There.
And what were we? Who is the online?
Dr. Glaucom Flecken, the ophthalmologist.
The ophthalmologist, but who spoofs nephrologists with excessive amounts of salt.
Yes, which is very triggering, as I mentioned earlier.
Yes.
We as a specialty hate salt more than any other specialty, even the cardiologist, I think. But yeah, so when I see that, it just bothers me.
So why do you think he does it? Why does he have that there?
I don't know. He's an ophthalmologist. He does really good with all these other specialists, but for that one,
Well, anytime they bring up lactated ringers too, all of a sudden the nephrologist shows up in his reels, like mad.
Well, actually, I started using that a lot more lately. There's been some studies that show that, hey, don't use normal saline as much, use LR more. And so I started using LR a little bit more.
Nice.
But I actually can ask you, what do you think of his interpretation of orthopedics?
Oh, it's pretty accurate.
Pretty
good.
Okay.
Pretty good. Pretty good.
Just good to know that. Okay.
Yeah, the ortho bro, right? That's the ortho bro is very classic for us.
Yeah.
Bone broke, me fix, sort of thing.
There you go.
That's classic. Or there is a fracture, I must fix it, even if the patient's in asystole, right?
There will be minimal blood loss.
Yes.
Yeah. That's my wife is an anesthesiologist, so about at least once a year I get that video sent to me. That's there's a patient in the ER. They have something called asystole. So I got to fix the fracture.
Yeah, of course.
So, but all good.
But you would have been proud of him. The other day, he did palpate a spleen on somebody. An orthopedist was doing an abdominal exam.
Oh, okay.
Yeah, we had a patient who had a pretty substantial trauma, but his CT scan showed that he had some splenomegaly. I was like, surely we're not going to be able to feel it. Yep.
You did.
Feel it.
Okay.
Yeah, that's crazy.
Those skills are still there.
It's still there.
Yeah.
Push her out. That's it. I think that's it. So it was.
And then
good.
I was like, hey, that's the liver. Come to the other side now.
Right. Take him from the prone position. See if you can feel it that way. Feel it better. Yeah. So the stethoscope. We had Dr. Monroe in here. Mm-hmm. So Brett Monroe, and he talked about auscultating hernias in the scrotum. So that was traumatic for me. Very traumatic. So I was like, come on, man. You're killing me. It's killing me. But very good. Very good. So what are some things, we talked a little bit about Top Golf, but what are some things that you enjoy doing?
I started picking up golf lately. I said I got fitted clubs. I've been out to the driving range a few times, and so I'm starting to get into that more. Other than that, I'm just kind of the typical, just watch a lot of sports and, just kind of take it easy. I got 3 young kids, and so they keep me pretty busy,
How old are your kids?
My oldest turned 7 in January, and then 5 and almost 2.
7, 5, and 2. That's awesome.
Yeah, all boys.
Taylor's are
8, 6, and 4.
Yeah.
Same age, similar ages. Mine are 15, 17, and 13. So I have 3 teenagers now in the house. Wow. All of which magically have turned to, it used to be dad's world. Now it's like a gigantic fight most of the time.
Yeah,
so
I get that.
It's all good.
When he always tells me just cherish these moments while they're young and stuff. And it's like, I'm trying to, but also I'm looking forward to them being a little bit more independent someday.
For sure.
In those same moments, where they're just screaming and yelling and bouncing off the walls.
Yeah. And the oldest two were relatively easy. And then the baby came and it's like, oh, we're back in that realm again,
Yeah.
Yeah. So, but it's fun.
That's awesome. That's awesome. How much call are you having to take?
We do weekends. It's like every fifth weekend ish. We were doing it a little less often, but then we decided it's just miserable to do 4 hospitals in a weekend. So we divided up and do 2 each, which is a lot easier to do. And then during the week, it's like once every 4th week. During the week, we get a call.
How many consults do you end up with on a weekend like that?
Depends. It depends if we're on listed as ER call. We maybe get 5 or 6 per day. But if we're not on call, we may get nothing or a couple here and there. We just kind of or if it's our established patients coming in, that's like the main ones that we would get. But
right.
It just goes with the routine,
And you're initiating things like dialysis and whatnot, or if they have anything going on.
Usually it's they have worsening kidney function. They just come into the ER that way, or they've been in the hospital for a while and then something happens, and then we kind of manage them. Very rarely do we end up having to initiate dialysis in the hospital, unless it's one of our established patients that we've seen for years, and they're like, okay, I have one that's going to the hospital now. He's like this close. And he feels fine, but, anytime he goes to the hospital, it's like, okay, this may be the time. And sometimes I'll be like, yeah, that's ready. Sometimes they're like, no, I want to wait a little longer. I'm like, then I got to learn. I'm like, okay, no more of this. Yes, we should be deferential to the patient, but, the old days of being paternalistic in medicine, we probably need to get back a little bit of that, because it's like, hey, listen, you need to start. If I was you, I wouldn't wait any longer, And so those are difficult conversations to have, especially in the hospital.
Right. Understanding that line between, this is really what's best for you medically, and you get to make your own choice kind of out in the land of Google and everything else that people can decide.
Yeah.
So,
yep. So that's most of our, and then we get a lot of ICU ones for, electrolyte issues and stuff like that. Those are kind of, they're there and they're kind of interesting, and sometimes they're kind of tedious,
Yeah.
Yeah.
And you end up working a ton with the hospitalists, obviously.
Yeah.
They've got a lot of medical patients, but then cardiothoracic surgery, cardiology, you guys are back and forth with them, I'm sure, as well.
I work really well with my cardio bros. I know every,
Nice.
I tell patients all the time, I know every cardiologist in this area for a reason. You got the same problems that affect the heart, affect the kidneys. So we work well together. In fact, I just got a message from Scott Bassett, who was like, hey, we got a patient of mine. He needs a heart cath later in the week. I'm like, yeah, got it. I'm like, do what you got to do. Don't worry about the kidneys. The heart's more important,
Yep.
So, yeah.
I get to say that to almost everyone.
Yeah.
Don't worry about the bones. Everything's more important.
Everything's more important. Right.
We're here.
For sure.
We'll fix it whenever we can.
Yeah. Please do. Yeah.
But yeah, that's super cool, man. It's that dynamic inside the hospital, I think, is so great. You have good colleagues that you can work with, and they paint physicians kind of like they're against each other, but you're working together so often and trying to get to the right spot.
Yeah.
It's good to have good partners that you can work with.
My dad was an end-stage renal disease patient, as I talked about. He ended up hemodialysis for a while and then went on to peritoneal. But it was funny one day. My dad was like a bachelor. He was 57 years old when he ended up having to go on. And I came to the LTAC. I came down from college to come visit him. And his cardiologist and nephrologist were playing Uno with him in that room.
Awesome.
At the end of their shift, just hanging out with my dad playing cards. And I was like, what is happening in here? And I recognized both of them immediately. And I was like, why are we playing cards? Like, oh, we typically do this on Wednesday nights. Like, they were friends. And this was an easy place for them to hang out. But it's like that. I mean, even still, whenever I went back to work in that area for a while, I worked in that region for 3.5 years. And yeah, I mean, they were tight there too. It was interesting dynamic.
Yeah. I mean, it's just great. I mean, it's good to have good colleagues. And I mean, that was the cool thing at Topgolf. We had, I don't know, there seemed like there was 50 plus people there, maybe, between hospitalists, surgeons, all the specialties. I think almost every specialty was represented there.
Yeah,
when we have the physician wine dinner, we've got, 150 people show up.
Yeah.
So it's pretty cool to be able to have that kind of a community here. And I think that's great for just the people that are here in the Woodlands and in the north side of Houston.
Yeah, and especially if you do outpatient, a lot of these people you never see in the hospital, and then you see them like, oh yeah, I know you. I send patients to you. I know your name, and that's how and so it's always nice to be like, oh, put a face to a name, and it's great.
Yes.
Yeah.
So on another note, totally different. I was just thinking about LSU. What do you think? What's the story? I know they're trying to recruit Lane Kiffin, right? And I don't know. I mean, I'm not an inside or outside enough to even know, besides what I see on Facebook and Instagram,
right?
Whether is You think they're going to get him, or you think he's?
I don't know, because they were just talking the other day. Like he's Lane Kiffin specifically is one of those characters that you can't really figure out what he's going to do. There's always like, well, what should he do? And I'm thinking you're building a program at Ole Miss that never had before, and you can actually have your name on the field if you do well in the next few years. Or you chase the money and go to your rival. And if you were to go to LSU, you got to play Ole Miss next year. I mean, that's But this is kind of the way college football is nowadays. As an LSU fan, I'm thinking to myself, I don't think it's right for him to leave Ole Miss to come to LSU. Now, if he's that kind of coach that he is, and he can be a recruiter and work in the NIL industry and all that sort of stuff and build a championship and we win a championship, then obviously I'd be happy. But I just, from a perspective of looking at it from the outside, I can understand how people be like, this is kind of not right,
Right. It feels a little bit dirty.
It does. And I think Nick Saban had a good thing on College Game Day last weekend. We were talking about that, and he was just saying how this is just the design of the way college football is now is just, they've gone a little too far, and so they need to fix it somehow. Who's going to fix it? What's the impetus to fix it? I don't know.
Yeah, how do they fix it? Because they've gotten slapped on the wrist bad enough about NIL money and how much money they were making before and all those different things that now who knows if they're going to be able to do it,
Right. So,
but yeah, I mean, he's a fun and interesting coach to watch.
Right.
But I also, like for me as an Aggie, Mike Elko, for me, I mean, he was a defensive coordinator there. He'd gone to Duke, was successful at Duke, but I don't know that there were, besides the people who were very much on the inside, I don't know that anybody was expecting him to be the one who they would tap to come there and to have a good year and have a good 2 years and now be where they are. Because I mean, A&M's got a chance if they can beat the Longhorns this weekend to be undefeated in the regular season, go to the SEC championship for the first time, be in the college football playoff for the first time. I mean, it's all crazy stuff.
Usually this is around the time when A&M would maybe let one go and crap the bed, but
they tried. They tried in the first half of the South Carolina game.
I saw that.
They tried. I mean, it was like, here we go.
Yeah.
This could be it. We may lose the next 3 games in a row, but then they pulled it out and then it was all good.
Yep.
So I mean, it'll be interesting. LSU, we had a lot. I trained in Birmingham, so we had folks who came up from Tulane and LSU at the time of what was the hurricane that was there?
Oh, it would have been Katrina.
It was Katrina. Yeah, they were got transplanted up because of Katrina, and so they ended up coming into the UAB Birmingham, Alabama area, and they were with us for the rest of our residency, and so that was crazy. But I mean, it's fun football. It's a fun place. Have you been to Death Valley at night? Have you been to a game there?
It's been a long time, but yeah, I have. It's intense. It's amazing.
I've never been.
Yeah. And after I finished, and I went there when I was in med school, I think, and then it was a night game and that was intense. And then after that, it's like, I just want to get back. And it's just, life gets in the way. But when everybody else talks about it, it's like, yeah, I was there 4 years plus a couple extra for after med school when I went, and I was like, yeah, it's an incredible environment.
That's super cool.
Yeah. And that was the time when we were terrible and we actually won a couple of overtime games, stormed the field. That was one of the famous ones was Tommy Tuberville, now Senator Tuberville. They beat LSU pretty badly one year, and when he was at Auburn, and then they came on the field and were smoking cigars and stuff like that. And then like 2 years later, we blow them out, and it's our turn, so we all storm the field and lighting up cigars on the 50-yard line. So yeah, that was intense.
That's crazy.
Yeah. So anytime they hear these stories at tailgates at LSU, I'm like, oh yeah, totally. Yeah, I totally believe all of that.
Yes. That. Not good for the kidneys. Some of those things.
Yeah, some of those things. Yeah. No, for sure. A lot of salt.
a lot of salt and a lot of alcohol.
Yeah.
Yes, for sure. No doubt. No doubt. Well, anything in terms of so a lot of things that we talk about leadership, we talk about health, in terms of just kidney health and overall kidney function for patients that are out there that need to be concentrating on being healthy as we kind of drive our way into this era of all the, there's a million different fads and different ways to not only lose weight, but strategies, and people are fasting. Some people are doing carnivore diet. Some people are doing all kinds of different stuff.
Yeah.
As you try to take care of your kidneys, right? I mean, obviously this is a huge filter to help us to keep our bodies healthy and safe. But what kind of advice do you have?
I generally just tell patients, I'm like, most of them they're all take care of adults. I don't take care of, young people, but it's like, by this point, you pretty much know what you shouldn't be eating, and so a lot of people have these habits and they're eating a lot of processed foods, a lot of salt, a lot of fast food. And, and it's just like, y'all should know better. And I'm guilty of it too. Like, I'm overweight. So I'm like, I know what I should not be doing. And so we kind of just tell patients that's what you got to be following, restrict sodium because, high blood pressure is prevalent. Younger and younger patients are getting high blood pressure. So, and it's almost like they look at you like, you really offended them. I'm like, oh, I dare you. I don't eat salt. And I'm like, I don't know about that. I know the diet in this area. I know what I eat, and it's got a lot of salt in it, But, I always tell people, if you want to do a fad diet, I'm like, listen, just try it, do what you think is right for you, but just be mindful that you probably need to have a well-rounded diet overall. If you want to cut something out because you just don't like it or you think it's bad for you, that's fine. But, I think when they try to get too aggressive and really restrict a lot of things is when people run into trouble,
Right.
So, and then lately, we've had a lot of people lose weight, whether it's through diet and exercise or the weight loss injections, and they do great. And then, they were at a point where they were unhealthy and they were on like 5-6 different meds, and then they lose all the weight, and then come to find out they don't need those meds anymore. But they don't know that as you're on your journey to get healthier, you need to be having a conversation with your doctor, like, hey, I don't feel good now. I was doing great. Now what's going on? Well, guess what? Now your blood pressure is lower and lower and lower. You don't need blood pressure meds no more. And God forbid they pass out, and because the blood pressure's low, they fall and they break a hip and they got to go see you.
Right. Yeah.
That's kind of I've had plenty of patients that do that. I'm like, oh, you should have stopped your meds. I play a lot of, armchair quarterback, oh, what you should have done was this, and,
Right.
But yeah, so that's kind of the general thing I would tell patients,
Yeah. Trying to be healthy.
Yeah.
Taylor's done 99 workouts at F45, by the way.
Congrats.
Thanks.
Congrats.
Yep.
I've done 0.
You've done 0.
He has to do one though, because in order to get one of our people who came onto the podcast, he had to agree to do one F45 workout, which can be cardio, resistance, or hybrid.
Okay.
I'm really thinking I'm going to put him in cardio though.
Yeah, just to make me throw up. I know she's going to do it. It's going to be so bad.
Yeah.
It's so bad.
Yep.
Yeah.
A lot of the people who are going there, I mean, they're taking, like, they just had this big High Rocks event where there was this like 3-day long workout weekend. And a lot of the people that I work out with went and did it. But they were asking me, several people were like, what are your thoughts on taking creatine? And I was like, well, number one, talk with your primary care doctor, because you got to make sure everything's looking good. Baseline labs are good. There's actually good research to say that it's good for muscle hypertrophy. Mm-hmm. You can see results within 4 weeks. 5 milligrams, or I think it's 5 grams a day.
5 grams,
yeah, is the recommended like starting dose. Monohydrate has been the one that's been studied the most, so starting there. And one guy looks at me and goes, so you think if I'm taking 30 grams, it's probably a little too much?
Probably. Yeah.
Probably.
I don't know.
You're probably stressing your body a little.
Yeah.
Just a little much. Maybe go talk with your primary care and let them help you figure out if it's a right supplement for you to take.
But that's the thing. Like, if a little bit's good, they think more is better, and just,
Yeah, when they were talking about like a mega there were some people who were purporting that you should do a mega dose to start, like a huge amount for several weeks, and then you titrate it down. I'm like, that sounds like something that should be monitored if you're thinking about doing that.
I don't know I don't know how creatine's processed, but I mean, eventually you just can't process it, right? You're just going to lose it.
Yeah,
it's going to pass through, and
I don't know if it's going to cause any harm necessarily. It does make more creatinine, so it could make your level go up, which means your kidney function is the same, but your labs look a little different.
Right.
Yeah.
Right. So you've got. Yeah. Huh. That's true. Yeah. That's interesting. Yeah, we see a ton of athletes, right? We see a ton of athletes who are, whether it's football, baseball, endurance athletes, cheer, gymnastics, volleyball. And so everybody's trying to find now that edge, right? They're trying to find the edge. And then we also get to see the athletes that are in their 60s, 70s, and 80s who are trying now to play pickleball and play, we get these injuries all the time. And it's like, and so we get to see I was on call this weekend. I bet you 60% of my patients were over 80.
Wow.
We had a lot of hip fractures this past weekend, a lot of pelvic ring fractures and injuries. And so that's crazy stuff.
Yeah.
So a lot of people who have a lot of medical comorbidities.
Yeah.
So we hand that all gently to the hospital.
Yeah. I'm like, don't worry, you got this.
It's
tender
all
loving care.
Yes.
Here you go.
Yeah.
And even one of them who was it? We had a patient, I don't know. Oh, he was taking Eliquis.
Oh, yeah.
Yeah.
He was taking Eliquis.
Yeah.
And then I talked to his family afterwards. I was like, we're going to have him restart his Eliquis. She's like, he hasn't been taking Eliquis for 6 months. I was like, he's supposed to be.
He's supposed to be,
And so anyway, it was pretty funny. And so anyway, but now it sounds like he knew what he was taking and she didn't know what he was taking.
Yeah.
So we're all back on the same page and back where we need to be.
Yeah, I heard the struggle. What are you taking? I don't know. Like, it's in my chart. I'm like, well, I mean, come on now.
Now, do you guys have nurses, MAs, PAs, nurse practitioners?
We have MAs in the office, and we have 2 NPs at the moment.
Awesome.
We're looking for more.
Very cool.
So, and we're growing, which is always a good thing,
Excellent.
So I think we're in a good spot, and we're just trying to optimize everyone and just keep growing,
But covering it, would you have plans for expanding past the kind of this north side, or are you thinking just optimize up here first and see how things go?
Pretty much optimize here first. I mean, we're, to have the manpower to try to expand maybe down the line, but right now we have opportunities to, it's a very growing area, as you know. And so there's plenty of opportunity for us to just kind of keep our foothold here and just really grow more in this area without having to expand territorially,
Sure. And if you were going to give advice to young medical students thinking about going into internal medicine, and then ultimately nephrology is another how many years after?
About two.
It's 2 more year fellowship after 3 years of internal medicine, right? Mm-hmm. So I guess not only med students but potentially internal medicine residents. What would you advise them in terms of moving forward?
So if they were already going in internal medicine, I would ask them, I'm like, well, are you interested in primary care? Because that's the first question. And most people, if they are, okay, that's fine. But if you want to go further and want to specialize, I would ask them, I'm like, well, what do you like about it so much? Do you like the hospital? Do you like inpatient care? Do you like outpatient? Do you like a little bit of both? Do you like the idea of having longitudinal care? Because that's one thing I'd done, because I was a hospitalist for a while before I moved here. And you see them for a while and they leave, and you don't ever know what happened to them, or they come back and they're admitted and they're seen by another hospitalist. And so you don't know what the situation is. And then here it's like, I get to see them. I've had people that have been here for 10 years and I still see them, and it's great. And I'm like, yeah, we've been doing this for 10 years now. We've been seeing you, and I've still kept you off dialysis, and you're doing great. And have a couple in particular who I'm doing great, and I thought he was going to be on dialysis by now, and he's not. I referred him for a transplant, and now he's too old to get a transplant. He's almost 80 now. So, and so I was like, this is remarkable. And so you don't see that in certain aspects. If I tell a young doc, if you want to get into a field where it has a little bit of everything, and I tell people like nephrology is kind of like internal medicine plus. We're kind of involved in so many other aspects of internal medicine. We work with the cardiologists, the critical care docs, obviously the hospitalists, infectious disease. I mean, even neurosurgery, if they call us and, they have a, internal endocranial hemorrhage and they're having renal failure, we would have to kind of help them. We can't do conventional dialysis, and we have these little nuances we have to do. And it's the things that we just don't see. And they use, hypertonic saline more than we do. And it's like, we get to argue about who gets to use it first, So it's just, we get to work with so many different people. And that's a key fun aspect of being a nephrologist.
Right. You get that. I mean, and that's super fun for me on the outside looking into those types of areas, is to see just that level. I mean, my wife is an anesthesiologist,
right,
and there's so much more to what she does than just putting people to sleep.
Right.
You've got to really understand, like you said, you've got to know what's going on from a medical standpoint, from all aspects, from all of human physiology, really. So that part I think is pretty
really cool. And we actually had a cool case. My partner did at another hospital, and it was with orthopedics, and we were dealing with infectious disease. They had a septic arthritis, and they were treating it, and they had to have a knee replacement. And they put antibiotic spacers in, and it comes back to the hospital, not feeling well, knees hurting, kidney function is getting worse. And it's one of those situations where we usually know why the kidney function is getting worse, and in this case, we kind of were like scratching our head. And then, long story short, we come to find out that the antibiotic he was getting was tobramycin spacer that was, for some reason, leaking too much in the blood system. So we checked the tobramycin level in his blood. It was off the charts. So they had to go back to the OR and take out a spacer. And so we had to interact with the pharmacist, the infectious disease, the orthopedic surgeon, and be like, hey, this is what needs to happen. And the patient ultimately did fine, but, it's like, interesting. This field always humbles you,
That's wild. Yeah, those antibiotic spacers are, they're kind of a beast of their own, because I mean, we just have vials of Vanc and Tobra that you're mixing into the cement, and then you're adding the polymer to try to make it all, like, once you add all that antibiotic, what normally takes 12 to 14 minutes for the cement to cure may take 30 plus minutes, just because there's so much antibiotic in there.
Right. Oh, wow.
And then you're trying to get that. I think I'm trying to think of how many. Classically, for like a septic knee, we may put 4 grams of vancomycin, and does tobramycin come as 1.2 typically in a vial? So 4.8 or something like that.
That makes sense.
So you have basically 2 batches of cement with 4 grams of Vanc, 4.8 grams of tobramycin, and you're molding that and then putting it inside of the implant that's going into the knee, trying to just get local elution of antibiotics. And so you can imagine, especially depending on how well it's mixed or whatnot, if you have a super, super high concentration, what ultimately goes in the patient, because all of that doesn't go in, right? There's just a small portion of what goes in. But if you got a high percentage, then you certainly could get a lot of antibiotics into that joint, and then potentially as the body absorbs it.
Yeah. I've never come across a case like that since, and that's very rare,
I've never seen it. I mean, we use Vanc pretty regularly into the joint. Like we'll put it into a gram of vancomycin into a surgical wound on a pretty regular basis. But when we were super aggressive with that, if they're on Vanc already for some sort of infection, then we can definitely see the kidney function falter a little bit.
Yeah. Cool stuff.
So, yeah, you get to be a little bit with everybody.
Yeah,
that's pretty cool.
That's what I like about it. And I would tell patients the same. I would tell young docs the same thing. I'm like, you get to do a little bit of everything. And so it's cool.
And then one of the other things we talk about a lot is leadership, right? Just how to lead teams and leading teams. You've obviously got MAs, you have your nurse practitioners, you've got your other partners that are there. How do you see for folks who are looking to get into medical leadership, whether they're leading their own practices, whether they're going to be leaders at the hospital, what kind of things would you recommend for people to do or to think about as they move forward? Strategies that work to help get people kind of behind you.
I mean, the short answer is just a lot of it does take time, and then, I mean, from a practice standpoint, being here for 10 years and we're still looking to add on more. So I'm still kind of more a partner at the moment, but it's like I was kind of one of the last ones to join. The other three have been here longer than I have. So it's be nice to have that leadership, but I have to have people to lead, newer young docs to mold them to get to a point where we can kind of branch out and do other things, like be part of a hospital leadership committee and stuff like that. So some of that's just time, being present, being affable, and being available. And so I don't have a lot of experience in that whole leadership aspect of in the area though. So, but I look forward to that in the future.
Yeah, it's a lot of fun. I mean, it's a good place. You'll get to meet it. I mean, working with hospital administration at Memorial Hermann or any hospital that you're at, really, frankly, if you have the opportunity, it's worth it to get in and start to just be a part of some of those different committees, credentials committee or whatever. You get in onto the inside a little bit and get to see some of the changes that you can make and some of them influence. Like, because you can put your head down and you can work and just work. But if you want to help influence things, it's a much bigger system. And it's when we worked at the VA, when I was at the VA, they told us you can push and pull the elephant all you want, but eventually it's just going to move wherever it wants.
That's good. I like that.
But on the inside from the inside where we are though, on the medical staff and whatnot, you do have that ability, I think, to help move things in the right direction. And I think as we move up here, I mean, my opinion is I think that we're going to be jumping up to a level 1 trauma center. We're going to be jumping up to more of a medical education type facility, because you have Sam Houston State that has their osteopathic school in Huntsville, and they have their first and second years are in Conroe. Texas A&M is now actively looking, trying to work with us to have some of their students come and rotate in the Woodlands. So we may see that happening over the course of the next 12 months or maybe 18 months or whenever. I mean, those things don't move super fast, but I think that that's going to be pretty cool in terms of that opportunity. But before you know it, there'll be people ready to do research and all kinds of stuff up here. I think.
Yeah, that's exciting to see how fast this area's grown. So just the 10 years that I've been here,
Because even for us, 10 years ago, we would have been level 3 trauma center probably.
I was curious if with the switch from level 3 to level 2, if you saw increase in consults and just with the acuity of the patients that they're accepting, I can see how that might.
Yeah, I mean, I don't know when they made that switch, but I just know that, especially Memorial Hermann, the trauma, of course, it ebbs and flows, But yeah, I've seen a lot of very interesting trauma cases, and they're always very key on like not telling me that part of it. They always tell me, the kidneys are shutting down. I'm like, yeah, I know that part, but I want to know what happened. Like, what kind of damage did they get themselves into, And that doesn't bother them as much. But no, I've seen a lot of interesting stuff with, what the trauma people have been doing. And I mean, it's amazing what they're able to do and how they're able to do it,
Yeah, I mean, from the standpoint of where we sit now with trauma, I mean, the trauma world is starting to open up a little bit. Like, I mean, I think we're going to have, as soon as we start having residents and start having people really coming in and starting to work, I mean, I think the idea of, they've already called it now Memorial Hermann, the Woodlands Medical Center, right? I mean, it's between Methodist, St. Luke's, Memorial Hermann, Texas Children's, MD Anderson, you've got a medical center here. You almost are going to have like this triangle between downtown, probably Katy and here, through the greater Houston area, I think. And so that'll be kind of fun. I mean, I think we'll get to have some grand rounds, some big things educationally that'll be coming, which is also interesting at least.
Yeah. So we were down in the city for a conference, for a nephrology conference just a couple of weekends ago. We interviewed some young people, one with potential for a job, and they asked us all these questions about acuity, and I'm like, What we see up here, we rarely have to send anybody downtown. We take care of everything up here in the Woodlands. So, I mean, it's nice to be able to tell people that. And like, you get to see some of the, the stories that we have. I'm like, I had one of these. And we always are in the office and we're doing clinic and like, I can believe what I just had last weekend, and it's remarkable to have those stories and then you can be able to tell people. And then as part you mentioned about leadership, maybe, hopefully that could be a way to bring more people here to lead them. And as this area continues to grow.
Yeah, I think it's going to keep getting, it just keeps getting crazier and crazier. And from a nephrology standpoint of view, how does things like technology, as we start to see not only AI, but for us in orthopedics over the course of the last 15 years, we have guys doing robotic joints. Obviously, I don't know if it was 30 or 40 years ago, but that's when the first people put scopes into joints. People were filleting people open to do ACLs, and now we can do all that through 1 centimeter incisions and whatnot. But how does that change for you guys as we move forward?
It's a lot of it's been very helpful in efficiency. We've been able to use technology to, as we go through the dialysis unit, for example, we were able to, real time see what their lab data is instead of having to dig through, arcane records. We can, adjust their treatment. We can look at what's going on in the office. We have, all these point of care testing that we can do. We have, home BP monitoring where they do that, and the blood pressure monitors automatically get sent to our office. And so, just that's a big step right there. And lately we've seen a lot of features in our electronic medical record where they actually composite a risk analysis. So we see these percentages. I didn't know what they meant at first, but it will kind of tell you hey, you have a percentage of being requiring dialysis or kidney transplant in 5 years, 2 to 5 years. Mm-hmm. And I don't know how accurate those are, but obviously you got to think. And then when I look at a patient and I see that their 5-year outcome of requiring kidney replacement therapy is, 50, 60, 70%. And I look at their case, I'm thinking, yeah, I could see that. What's the likelihood I'm going to see this guy on dialysis in 5 years? And so this actually gives me a number, and I can tell the patient that, hey, we got to do X, Y, and Z. Otherwise, this is where you're headed, And I think once you see those numbers and they see those numbers on a screen like that, then they're like, okay, oh, he really told me that, And so rather than they can say, what's the chance of me being on dialysis? And you're like, oh, good chance, not so good chance. That doesn't really give those information to the patient as much as a percentage. And when they see these, these models of what AI can do, it's like, okay, well, more information for them gives them the tools to be able to do the right things, So.
Yeah, absolutely. We keep seeing it just more and more everywhere we go. We go. It just keeps coming.
Yeah, for sure.
But I went to the Woodlands Economic Conference 2 years ago, and they had a bunch of oncologists there. Not only oncologists, but oncologic researchers and research companies who, for the first time, really, really in my life, this was 2 years ago, where basically people were saying we're going to have cancer cured in the next 10 to 15 years. And I was like, really?
Yeah.
And, because I'd never heard anybody really talk like that.
Mm-hmm.
I've heard people talk pie in the sky like that. Oh yeah, we're going to get it. We're going to whip cancer, all that stuff. But they basically said, if you take this technology and we use it the right way, then it's like having 10,000 research oncologists doing 10,000 careers of work over the course of 10 years. And so that you can, in terms of mapping all of the DNA and mapping the what they need to do in terms of gene targeting or whatever it might be, they can theoretically run all of those analyses without having, what would take one person's entire career can be done in a month.
Yeah.
That's crazy.
Yeah.
Craziness. Sure. But it's wild. Now we just need to get them to teach us how to get our kids to behave. Good.
Right.
Yeah. For sure.
Oh, I don't know that can be taught.
It's doable. It's doable.
AI is just going to be like, this is hopeless. No thanks.
Yeah.
You're on your own.
Yeah.
Well, it's crazy, man. Taylor laughs at me because I tell her cherish the times with your kids, man, because those little guys, it's so awesome because, we talked about it. We talked about it early on this podcast for me, but it's like my 15-year-old, I cannot remember. It burns me up because I can't remember when was the last time that he sprinted across a room and jumped up with both arms and both legs and just Garfield on the on the car window, he jumps up and gives you that hug. And I'm like, that was one of my most favorite things ever. And I can't remember, was it 5 years ago? Was it 8 years ago, and you just don't know when that last time is coming, And so that part to me is like, just with you got young kids, man, just cherish that time.
I remember when my first one was being born, I was talking to an infectious disease doc. He was sitting there. He's older. His older kids are in his 20s, whatever. And he looked at me and he tapped the computer screen and he said, "This will always be here. Your kids will only be the small ones." And ever since then, there has been a shift. And my partner at the time, whose kids are much older, they're about your kids' age, he was like, "Hey, they're going to be going to college in a few years, and I'm not going to hardly see them." And so he made an effort to balance that work-life relationship. And, and so for me, the same thing. So now my work schedule goes around their schedule. And it's remarkable to be in a field that allows us to do that. We're still pretty busy, obviously, but we have that capability to do that. And it's just nothing more rewarding than to be able to do that for your family, to be there for them, especially when they're this young,
Mm-hmm.
Yeah.
Yeah, absolutely.
We talk, that you bring up balance. That's one of my big things that I've tried to talk about a little bit with folks. And I had a chance to talk with some med students at Sam Houston State actually a couple weeks ago, but that idea, like if you want to be balanced, like if you want to be a great doctor, if you want to be a great nephrologist, if you want to be a great surgeon, if you want to be a great whatever, that now you have to be imbalanced, right? You have to be focused only on doing this. And I'm like, that's not true. Like, that's why people get so burnt out. Now, can you be a great father and a great physician? 100%.
Mm-hmm.
You can do that. Can you be a great father, a great physician, and a great midnight DJ partier, probably drunk and high? Probably not going to work.
No.
Right? Like you're going to have to give up something.
Of course.
But you can have a balanced imbalance, right? As long as that balance, if for you, is going towards the good of yourself and your family, right? You working and doing a great job taking care of patients is going to help make you a better dad, right?
Mm-hmm. Yeah.
And you being a good father is going to help make you be a better practitioner, in my opinion.
Yeah.
So
no, I agree totally.
So I don't know, Taylor.
Yeah, absolutely. I agree with that 100%. I think that, and again, just thinking back to my own history, when my dad was on hemodialysis, he wasn't able, he was very, very sick when that started. And it was at a time where one of his daughters was about to get married and I was about to graduate college, and he was worried about being able to make those events and travel. And so he was a decent candidate at that time for peritoneal, but it was because of that nephrologist who looked at him and said, "Look, you've got 4 young kids. I understand that having to go and sit for this many hours, this many times a week is draining you. Let's try this. It may not work. We may have to switch back, but this is an option, that allows you to go, and they'll deliver your stuff to the hotel so you can go to your daughter's college graduation.
Sure.
And it won't affect your schedule." And I think that because he was also a father and thinking about things that way, he was able to relate to his patients more and was a better doctor. That to me I think the two play on each other. Now there's some things that are incompatible, like you said, being a midnight partier and altered, probably not going to get you to that goal quite as much.
Right. But I think that's where people lose it. Like people, when they think about balance, they think about, well, I've got to give up the fun stuff. There's a lot of fun stuff that's not bad for you.
Absolutely.
You know what I mean? There's a lot of great things, like being able to go out and play golf and enjoy your time and savor your mental health a little bit is great. Now, going out for 7 hours on a Sunday, if you haven't seen your family for a week, probably not the best idea, right? It's exactly. But going to Topgolf for an hour and hitting balls and enjoying your time is like, this is good. So
100%.
I found that a little bit. My golf game dipped, but that was one of those things. I enjoyed golf, but I didn't enjoy it enough because for me, it was like, get out there an hour early, go hit balls for an hour, 4-hour round of golf, then hang out after the round of golf for another hour at the clubhouse. And then you get home another 30 minutes later, and my wife's like, "It's been 8 hours." What have you? It's like, I was just playing golf. Come on, it's no big deal, And so I was like, "Listen, my kids enjoy playing golf, but we'll just go to Topgolf. We'll go hit balls for an hour and then go do something else."
That's great.
And so
that's awesome.
It's a lot of fun, and there's plenty of people whose kids love that would be really cool, right? To have your kids love playing the game. And being out on the golf course with you, that would be pretty fun.
For sure. Mine are still young, so I don't know which one of them. I think my oldest would probably get into golf. I think I can see that in him, but it's kind of fun to see what these kids turn into,
Yeah. Well, and that's the beauty. You just never know.
You don't know.
My kids, I have a kid who's a swimmer and a swimmer and football player. And then my middle son is a long distance runner.
Okay.
It was like, well, we got to figure out, the paternity test on that one. But I mean, Caleb's running like crazy. He's probably going to run somewhere around a 4.5 to 4:20 mile this year as a sophomore in high school. And I'm like, I could not run that fast if I was being chased by a bear with a knife. Like there's no way that I'm getting away from doing that. Yeah. And then my daughter's playing tennis and volleyball and doing all kinds of fun stuff. So, but I think it's just so cool. I mean, because you're right. You just never know. You never know where they're going to be. But if they find something they love, if they can see that from dad, right? If they can see that you have things that you're passionate about, that you love, that are building you up, right? That part is super cool because then they can look to you and say, you know, whatever. I love theater arts, or I love journalism, or I love gymnastics, or whatever it is, and go after it.
And that's kind of the hardest part. You know, you're being a doctor, you're working hard, and you have young kids, and you're being a dad, and then it's like, who am I? What am I going to do, right? Because you have to mold yourself to be something that your kids are going to look up to. So to be able to carve out that self-care is something that's one of the hardest things I've ever had to do, and I'm still working on it, but I've come some time now, and so. You know, like, what do you kids do? Like, well, I'm exhausted at the end of the day. I'm like, you guys do whatever you want. And I'm not going to push you to do soccer or this if you don't want to do it. So you just find your path. But you got to find that, you got to give them a drive. And you got to say, well, listen, this is what dad's doing. What's the drive that he has? What motivates him? And then hopefully you can instill that fire in them to do whatever what they want to do.
Absolutely. Yeah. Absolutely. And they'll see it, though. They'll see that from you. And that's the part that, as you start to see them grow up, you start to see those little things, right? Those little things that having you be there to help is so important. And you know, it's like we talk about just, I've talked with my kids, just visualize what you want to do. Think about where you want to be. Like, if you want to be successful, you got to picture yourself being successful. You know, if you can't see yourself succeeding, then it's going to be hard to get there because you won't be able to. And then I have one of their friends comes back to me and is like, hey, Dr. Piefer, I was picturing myself being successful. I was like, I'm not sure if you're making fun of me or not, but I'm going to take it as a win. Taylor's like, he was making fun of me.
Most definitely, but I'm glad you see it as a win.
Yeah, I took it as a win.
That's good. Like, take the win. Take the win.
Always take the win.
So always very good. Well, I want to thank you for coming. Thanks for being a part of the podcast. Thanks for coming out here. We are just, you know, frankly blessed to have you here.
Thank you for having me.
It's awesome to have you. We do have for you pecan pie Thanksgiving coming tomorrow.
Yes.
Hopefully pecan pie is a favorite for you. Do you have a favorite Thanksgiving food?
That's probably right there.
Yeah.
And of course, mac and cheese, you know.
Nice.
Yeah,
of course.
Nice.
You know.
I've asked probably in the last 2 years, the last 2 years I've been with you for Thanksgiving, I ask most of the patients I see during those days, like, what's your favorite Thanksgiving food? And I think on one hand, I can name people who said turkey.
Oh.
Most people say sides.
Yeah, it's all the sides.
It's the sides.
For sure.
I had one this morning, a little girl tell me that turkey was her favorite. I was like, interesting.
Must have been fried, I guess.
Yeah. It's got to be fried turkey. Got to be fried.
With my kids, they said, Felicity says mac and cheese, but I have 2 kids that have PKU, and so they're real restrictive diet. And so Whitney says, like, the most interesting thing, she's like, fruit salad, which is not a traditional Thanksgiving.
No. Okay. Yeah.
But it's what she likes.
That's great.
Yeah,
That's awesome. Yeah, sure.
Well, very cool. Well, I want to thank you so much again. I really appreciate it. I think that you rock, man.
Oh, thank you for having me.
Keep it up. Keep it up.
Thank you.
We got to give you some applause, though. And lastly, the band.
It's the same song every time.
That's only one button.
Oh, yeah.
He does this very safe dance here. You know?
It's a good dance. Yeah. I don't even care what you say.
It's great.